So I wanted to just give you some definitions. A lot of times we make assumptions while we're doing this work that people understand what the terms mean, what the acronyms mean. And so here we talk about the fact that many patients face obstacles around health equity and health disparity. Hopefully we all know and believe that to be true. If not, hopefully today during our conversation, we can give you some insight on that. And this talks about how racial, ethnic, religious, and other marginalized groups of people are disproportionately affected by preventable, and that is a key word to me, preventable disease and increased death and disability. And so here is a meme that most of you are likely very familiar with because it's been on Facebook and other social media mediums for years that depicts the difference between equality and equity. And when people see this, unfortunately, some people believe that this graphic has issues. They believe that this looks like giving just a little bit too much support and attention and a little bit too much help to people. And that is unfair. So this is to help you define the difference between equity and equality. So equality means you give everybody the same thing, right? And that makes assumptions, because if you believe that giving everybody the same thing creates equal access and equal experience, then that discounts the long history of longstanding suffering and discrimination and marginalization and disenfranchisement that different communities face. So giving everyone the same thing equally does not work in creating equity. When you are looking at equity, you're looking at giving everyone what they need. And so that is a difference we wanted to point out today. But at the same time, knowing that ultimately our goal is liberation. And that means that, we know it's a long road. We know it's a lot of work to get to where we need to be as a community, as a society. But ultimately, the goal is to remove the barriers that are systemic and that exist, that create these inequities for people, and to really level the playing field. And so I like to talk about equality and equity, but to remind people that ultimately where we really want to get to is liberation. And we believe, leaders in this work believe that it is possible. We know it will take time, but we believe that if we are relentless in our pursuit of health equity and in tackling the issues, and if we are relentless in being willing to have the conversations, that it is possible. Health equity is achieved when everyone has the opportunity to attain. So everyone, right? We don't want people to be disadvantaged from achieving potential because of their social positions or other socially determined circumstances. You'll hear a lot right now. It's a super hot button topic to talk about diversity, equity, inclusion, or DEI. And that is not just about racism. The mere mention of racism really scares people in a way that stops them from having the powerful conversations that need to be had to make sure that this work is done. Not just racism, homophobia, or any other exclusionary term. It just scares people because we don't want to be classified as a group of people that are discriminatory or as a group of people that contribute to the leaving out of others, right? But there's a little bit of acknowledgement that has to happen in all of our conscience to be able to successfully move the dial forward. So this says that health inequities are reflected in differences in length of life, quality of life, rates of disease, disability, and death, severity, and access to treatment. So can you imagine, and many of you who are tuning in may be able to, can you imagine your length of life, okay, your severity of disease, and your access to treatment being altered simply by who you are? Simply by who you are. Something that you have no determining control over, just who you are, resulting in increased, tragedy medically in your life. And so what we want to talk about is not just the isms. We want to talk about access, and we want to talk about experience. This transcends, the racisms, the homophobia, the thisism, ageism, or whatever. It goes deeper, and it talks about really what are the lived experiences of people. And if you don't identify with one of these communities, it's great that you're here, because we can help inform you about some of the experiences that maybe you're not even aware of that people who are members of other communities face in their healthcare journey. And so this says, and I think this applies to everyone, right, that visiting a healthcare provider requires vulnerability. We all know that, right? You have to discuss your body. You have to discuss your mental health. You have to share, a lot of times, intimately personal details. That alone dissuades many people from getting medical treatment. That alone, right? That level of having to be vulnerable. A lot of times people choose to suffer in silence. But add to that an experience where you feel healthcare professionals aren't listening to you, specifically because they don't identify with you, right? Add to that they are being dismissive to your questions and brushing off your concerns, right? And this is a reality for many patients who are members of communities that aren't considered traditional and normalized, okay? And what we know is that people don't get into the medical career, people don't get into the medical field, which is filled with servant leaders, to be discriminatory. They don't get into the medical field to be harmful. They don't get into the medical field to leave people out and to be dismissive. But what happens is our human nature, right? And what we innately are taught as we grow in society seeps into everything we do. It seeps into my work in nonprofit management. It seeps into the work of people who are healthcare professionals. And then your judgments start to affect how you relate to other people. It is sometimes the most subconscious thing. It's not necessarily intentional. I would venture to say that in some cases it can be, but it's not always intentional. Medical professionals are, by the nature of what they've signed up to do, there to help people, right? They are people who have decided they want to help other people, but just who we are in our human nature sometimes causes us to fall short. So this says that these people and more, people that fall into these groups and others, face health disparities that are linked to stigma, societal stigmas, discrimination, and denial of their civil and human rights. We have to acknowledge that, okay? Here's a quote from the Chief Diversity Officer at the University of Washington Medical School of Medicine. Okay, this acknowledges healthcare disparities and biases, right? They're part of just the inequities that exist in society. So we can't believe that our society is flawed, that in society people face discrimination, that people face exclusion, that people face harmful treatment, and people face being marginalized. We can't believe that and then believe suddenly that when we go into the healthcare setting, that all of that just goes away, right? And everyone has the same experience. So this says it boils down to certain groups receiving more benefits than others, and that is historic and present today. I love that, right? Because this isn't new. This isn't new. The conversations are just starting to emerge in a way that's powerful and that are solution oriented. And this has everything to do with privilege, which we'll talk about a little bit more. So unconscious bias, this is terminology you'll also hear in this work. It is unintentional stereotyping, okay? We are all holders of unconscious bias. No one is exempt from it, okay? You can, in your learning and your willingness to expose yourself to other cultures, communities, types of people, you can start to combat your unconscious bias, but we are all holders of unintentional stereotyping. And unfortunately, it can lead to the holding of false beliefs, even in the medical field, right? Bias means that some people will end up having subpar treatment, right, for what are normally very treatable conditions. And this can in turn lead to catastrophe medically. It can lead to inadequate care and real health consequences. Okay, so I'm here today because I told you I identify with a community of color. I identify as an African-American woman. And because of that, I have membership as a person of color. And it gives me not only the right and the experience and the perspective, but it gives me the responsibility to help educate what I know about my own community. So today, I'm here to talk, and Jen is here. We're here to talk where we feel like we're best suited to speak. And so I would like to just talk very briefly about some challenges that people of color traditionally face in healthcare settings. BIPOC, okay? A lot of people are like, what is that? So BIPOC, it is a fairly new term. It originated in about 2018 and 19. It's used pretty commonly now, and it stands for Black, Indigenous People of Color, okay? And this relates and highlights the unique relationship that Black people and US Black people specifically, so United States Black people and Indigenous people have to white supremacy. So it's not just being melanated. There are plenty of melanated people that don't have the African American experience, but BIPOC really points out that Indigenous people and Black people originating, Black people in the United States have a increased experience with white supremacy. And so this term is one that you'll see being used in this work. So this says that BIPOC people have an increased tendency to shelve their health. What does that mean? I mean, that is something that, if it's true, should definitely be considered. So why? And here's where we get to talk about privilege. And I love hearing Jennifer talk about it even more than me, but I love talking about privilege because it's so eye-opening, right? Because as soon as you feel like you lack privilege, there's someone else that can point out how much privilege you in fact do have. And so in this instance, where it says people of color have an increased tendency to shelve health, it is because life is hard for everyone. I love that. I love that acknowledgement. So I don't care what community you belong to or what your who you are innately or what you've experienced. Everyone has ups and downs. Everyone has challenges, and we acknowledge that. But life is a little bit harder for people in our myositis community, of course, because you're living with a chronic illness. Okay, so right there, life becomes harder. But what additional crises are people in our patient community facing, right? What additional crises do patients of color specifically experience that disrupts their ability and their privilege to prioritize their health? And so this is a challenge we have to acknowledge and we have to integrate into our solution-oriented work, right? Where we as an organization are looking at how to help patients and we're looking to find solutions. We have to understand what the patient walks in with, right? Okay, it's a patient who's living life, so there's already a significant amount of challenges that are being faced. It's a patient now that's living with a possibly rare disease, myositis, incurable chronic illness, okay? And then now what is on top of that? And so when we look at the past year, all of us have lived through this global pandemic, and it's been, I would challenge anyone to say that it's been difficult for everyone, right? But there are other people who, in addition to the global pandemic, have had to deal with economic crisis, right? Whether they've lost their job, they were already underemployed, they've had situations maintaining their income or their income levels have decreased because of societal changes. Many people, even affluent people, suffered greatly over the past 2 years, specifically in the beginning of the pandemic, by losing retirement funds and losing investment funds. And so there are some subset of our community that also have dealt with economic challenges. And then add on top of that, if you are someone who has dealt with the racial injustice that has really taken over our society, specifically in the past couple of years, imagine throwing the stress of that on top of your situation. And then you can start to understand why some people have less privilege to prioritize their health. Okay, there are also stigmas in community of color that lead patients to choose between faith and care. I'll tell you, in the African American community, there's a tradition that if it's something horrible going on in your life, that your family and your friends and the people in your community tell you to pray about it. Okay, and it's been very difficult in this community over the years to create understanding that you can pray and seek help, right? And they're not mutually exclusive. And now you'll see a lot of houses of worship really focusing on letting people know that you can pray and you can have faith and you can rely on your faith while still seeking out support and help. Many patients of color suffer in silence, and many equate illness with weakness or emasculation. So I've even heard doctors that I've spoken to say that Black men don't complain. And I can't speak for all Black men or all Black people, but in my experience and hearing that enough times and then knowing it in my own, circles of relationship, it has some truth to it, that Black men don't complain. They're less likely to seek support because in some communities, seeking support and seeking help and being vulnerable is equated with weakness, okay? People of color face discrimination regularly, even at the doctor's office. Okay, newsflash, that shouldn't surprise anybody, but one of the studies that I read about talked about not just the person of color's experience in the doctor's office, but what does the person of color experience even well before that, when they're calling to make the appointment? Are there times that they're feeling there are microaggressions? Are there times that they're feeling assaulted in their interactions, even when they call to make the appointment. When they pull into the parking garage, what's the experience? When they get on the elevator with other people, what's their experience? Are they facing discrimination? When they get to the information desk. So all of these things and interactions that happen well before they get to the practitioner start to color their experience and start to color what they think about going to get medical treatment. And so that discrimination is a, deterrent from them really establishing trust in these medical settings and hospital settings. And then there is just globally a lack of interpreters and cultural mediators to help patients and doctors connect. So obviously, if there are language barriers, that's going to be an issue, but also cultural mediators. So you'll hear people talk about cultural competency, right? And there's just not enough training around those issues. There are things in communities and in cultures that create nuances in how people move, what they think, what they believe. And if that cultural competency is not there and there aren't mediators available in the healthcare setting, sometimes that can result in a negative experience for people of color. And then historical experience. Okay, hopefully, and we don't dwell on this, but we have to acknowledge it, right? That specifically in communities of color, there is a distrust, a historical distrust of the medical community, okay? And that is not out of the blue. It is substantiated with fact, right? In historical instances, there has been a history of mistreatment by medical establishments. There have been, inhumane experiments on groups of color. There are forced sterilizations and the withholding of treatment, right? And we can all Google and look up some of these examples to know that when these things happen, and they didn't all happen thousands of years ago. These things happened maybe 2 and 3 and 1 generation ago. And so these are the stories that are passed down in families that lead to distrust of the medical community. And one representative of that is the fact that last November, only 42% of Black Americans were willing to participate in getting the COVID vaccine. In the African-American community has been one of the hardest to educate and persuade around the vaccine, because there's just a distrust historically of medical professionals. And that's so unfortunate, so unfortunate. And then this is important to know, and people may not know this, but people of color are consistently undertreated for pain relative to white patients, okay? I mean, who would think that, right? And that is because studies show that 50% or more of medical students and residents hold false belief, okay? Hold unconscious bias about biological differences between people of color and white patients. They specifically have surveyed and found out that these medical professionals literally feel like people of color can tolerate an increased amount of pain, or that their nerve endings are different. And because of that, it really affects how they treat the patient, what they prescribe for the patient, what level of service they render to the patient. And this is just preposterous, right? It is preposterous, but it is a fact. So if 50% of medical students believe that, then who are we putting into our healthcare facilities? Who are we training to be the next generation of medical professionals? And then what experience do people of color have when they are seen by these professionals, right? According to Centers for Disease Control, Black women are 4 times more likely to die from pregnancy-related deaths than white women, okay? And many studies show that that is considered a lack of being heard, a lack of being believed when symptoms and issues are reported. And then another study found that 53% of Muslim women delayed seeking medical care because of modesty concerns. And I know in my previous work that I've experienced that with Orthodox Jewish community as well, where their modesty concerns aren't respected and aren't observed in healthcare settings. And because of that, they don't receive the treatment that they need to be successful. And so what I want to say is that organizations like the Myositis Association and healthcare professionals have to do this work. It's a must. It's not optional. We cannot put forward a mission that says that we want to get to a cure and we want to change quality of life, but leave people, human beings behind in this conversation. And so we are all charged to acknowledge these issues, to act on them, and then to allow them and to infuse them to set the tone in our work. Okay. Many of us are looking for and then dedicating financial and informational resources in our work and looking at who we can partner with, whom we can partner to leverage resources. Okay. We are solidifying our commitment to equity and to this work. And we want to identify where the disparities lie. We're talking to patient communities so that we can come up with action steps to close the gap. And realistically, we are confronting the isms within our own organizations. Right? We have to acknowledge that this is not an external issue. We all have participated in creating this systemic system of disinclusion. Okay, and so the first thing is to acknowledge it and then to put forward the good work that will resolve it. And specifically in relating to people of color, you can't do the work without them. Okay, and so that means that we have to create spaces for people of color, and I'm sure Jen will say the same thing for people in her community, to come in and to support the work, to inform the work, and ultimately to lead the work. Okay, and so here are a few ways that people of color can advocate. If you feel vulnerable or discriminated against in your healthcare journey, right? Trust your gut. Okay, trust your gut. If it doesn't feel right, and this is for anyone, whether it's equity issue or you're just a patient who seeks out medical care and you don't feel quite right, trust your gut. Okay, do you feel dismissed? Do you feel like you were heard or were you talked over? Right? Do you feel judged? If you suspect any kind of dismissiveness or bias, or you just don't feel respected, don't hesitate, move to someone else, okay? It is important that you are in an environment where you feel comfortable and you feel that it's a good fit. And then you have one more responsibility, right? You have to file a formal complaint if and when you are the victim of something egregious, right? Why? Because you have a responsibility to the people who come behind you, okay? So if it's egregious and if it's abusive, then you must file a formal complaint. And all the studies show in hospital settings, specifically, that when people of color advocate for themselves, it improves their health outcomes. The hospital administrators are looking to resolve these issues. So if you don't speak up, they don't have the opportunity to be informed by your experience. Okay, prioritize yourself. This is easier said than done. Gosh, I'm sitting here on like 2 hours of sleep right now saying this, right? But in communities of color, people are often trained to put the needs of other people before their own. Okay, we take care of our family members, and this is not exclusive to communities of color, but specifically in communities of color and immigrant communities, and it's very there's a heavy load of familial responsibility, right? And not just our immediate family. We take care of the community, right? And so we get into a rut of making sure that we're taking care of everyone else, and we are doing what we need to do for everyone else. And we're letting the things and the needs in our own lives and our own healthcare slide. So we have to advocate for ourselves by learning how to prioritize our health and prioritize ourselves. And then understand that genetics are indeed in play. Genetics are in play. There's so many diseases, chronic illnesses that are related specifically to your genetics and to your cultural background, right? That there are diseases that manifest differently depending on your genetics. And it's important to understand that. Genetics play a role in some conditions, and it may require different care for people of color, okay? I had a situation with my own healthcare provider where she printed an order for me to go get lab work. And for the first time, I think you might have seen this, Jen. For the first time, I looked at my information on the form, and where it had race, she had written multiple. And I was like, well, who said, who informed that? Like, that's not, I don't identify as multiple, right? And to me, that was problematic because I need to be identified as who I am, so that if there are illnesses or variances or nuances that affect African-American women differently, that it is acknowledged in my medical chart. Okay, so don't make assumptions. I need you to ask me and to make sure that my genetics play a role in how you evaluate what's going on with me. And on that note, it's okay to ask. It is okay to ask. If you have a medical professional with whom you're vulnerable, and think about it. These are people who see you, unclothed, who know what's going on inside of you, who know the inner workings of your body. And if you can't ask them a simple question without it being an issue, that's probably the issue. So it's totally okay to ask, if you are identified as a person of color, to ask your treating physician, how will you manage my condition as a person of color? And they may say that your condition has no variances because you're a person of color, and that's fine, but it's okay to ask that question. Look for representation. So this is a tricky one because obviously the ultimate goal is to get the best possible health care and outcome for your condition, regardless of anyone's race, ethnicity, how they identify, what their lifestyles are, who they are. It should not matter, right? None of that should matter. The goal is to get the best possible health outcome. But with where we are as a society now, it is completely okay that you do what makes you most comfortable. And in that case, for people of color, that may include considering the benefits of a same race or same ethnicity doctor. But what I would always say is that I would weigh the benefits of that with the benefits of being with someone who has the most expertise and resources. Because at the end of the day, I want the best possible care, and I don't care who I get. They could be green, purple, yellow, or whatever the case is. I want the best possible care. While we do this work to make sure that everyone can receive the best possible outcomes from anyone. And then complete the survey. So if your hospital, your medical practice gives you a survey, they are wanting this data about your experiences so that they can inform their decisions where they can inform where they'll invest. What are the areas of work where they want to have solutions, where they want to improve their service model, and they can't do that if they don't have feedback from you. So fill out surveys whenever possible.